Hello everyone. Welcome to the second edition of Indian Stents Get Updated, brought to you by Express Healthcare. I'm Viveka Roy Chaudhary. Today we are talking to Padma Shri Dr. Upendra Kaul from Batra Heart Centre, a pioneer in interventional cardiology in India. Dr. Upendra Kaul, thank you for speaking to Express Healthcare and welcome to the show. Now, you've been part of Indian Stents Get Updated last year and years where we get interventional cardiologists to talk about the changes in the interventional cardiology industry over the last decade and what's going to happen in the next decade. So what are your views? What can we look forward to in the next decade of interventional cardiology?
Well, interventional cardiology in India has come a very long way. I remember angioplasty started in 78, 79 in Europe, Zurich to be precise, went to United States. And we in India started our coronary intervention program using a simple balloon because stents were not there. That was around 81 when 2 or 3 of us in different parts of the country started the procedure. Who did first doesn't matter. And from there, we went ahead. Those were the initial days of angioplasty. Angioplasty was meant for very small, selected population, maybe 1% of the patients of coronary artery disease, with very simple lesions. But even with simple lesions, it was unpredictable because when you traumatize a vessel, using a balloon, basically it is trauma, controlled trauma, but it can get out of control and artery can get blocked because of dissection, injury, perforation. So surgeon had to be giving us a standby. We will not finish the procedure till the time surgeon tells us that he is not ready now. So we used to do it first thing in the morning in All India Institute of Medical Sciences with Dr. Venugopal watching us, and he would say, let me know when I can start my first case. Don't come sitting on the chest of a patient and when we were operating, because surgery was also in its beginning. There is 1 operating room or 2 operating rooms, not like 12 operating rooms now. So then we slowly migrated to the Stent Era. And Stent Era came around 97 when simple, crude metal stents came, but that was a big boon because the acute problems vanished, because after dilating the lesion, you put in a scaffold and then it will stay there. It will not allow results to get vitiated, at least in the first few days. So surgical standby was not required. But then we started seeing recurrences, especially in those patients who were diabetics. And as you know, 1 out of 3 patients who comes to cath lab in India, in most busy centers, is a diabetic. And sometimes the arteries are small. So in this patient population, recurrences were more than 10%, to say very conservatively. And then came another revolution. Drug eluting stents. That means stents coated with drugs which would not allow too much of healing to occur, so that the vessel does not get occluded because of healing, because restenosis is a healing process which gets out of control. And I remember 2002 stents, drug eluting stents were launched, but I was fortunate enough to start using them in December 2001. Because I was part of a study from Boston Scientific using paclitaxel eluting stent Texas. So my experience is from December 2001, but in India it came in 1st of June 2002, when 2 stents were available, One was paclitaxel eluting stent Taxus, and the other was sirolimus eluting stent, the Cypher. These are now called the first generation drug eluting stents. And the restenosis rates came down substantially, single digits, 2%, 1%, that kind of a thing. And it continued for some time when we started seeing some of the problems. And those problems were because of the polymers which were used. Because these polymers were permanent polymers, they were not safe, and they would produce inflammation. And I remember in one of the European meetings, there was a big furor that stents are like ticking bombs in the arteries of the patients, which can explode any time, years after implantation. And it was a huge outcry. The percentage of stents implanted started coming down. And till the time cardiologists all over the world met and deliberated on this problem. And then it was seen that it is a problem, not so alarming, but at the same time need a solution. Came the second generation stents, again with polymer, and the market leader today, the Xience stent, that is everolimus eluting chromium cobalt stent with a durable polymer. The polymer is fluoropolymer, which is very safe, very benign, and in fact some people say that it is anti-clot, anti-thrombogenic also. And that polymer has stayed with us till now. So that became kind of the gold standard. And then other companies like Boston Scientific and others also got this particular drug with different names. Sirolimus was the first drug to be used, then other limus drugs like everolimus came on board, zoterilimus came on board for Medtronics, and these stents started. And they proliferated the market, and stenting became quite safe. And with the result that it appeared that we have reached the zenith. But then, 2 years ago, we started looking at the newer generation stents. And my friend Sripal Bangalore from New York University, he carried out a meta-analysis in which stents which are thin strut. Xience has a thickness of about 81 millimicrons, and he defined 70 millimicrons as the threshold. Any stent less than 70 would be ultra thin. So he showed that ultra thin stents, the target vessel failure was lower because of reduced myocardial infarctions and reduced chances of stent thrombosis. There was no difference in mortality, but these are two very strong events. And the reason behind that is, number one, you don't require so high pressure to deploy them. Number one, they do not compromise the branches of the artery. And number three, the fluid dynamics, the flow dynamics through the stents with these ultra low thickness stents are better. And then started the era of ultra low thickness stent. Now, Indian stent industry actually again has a old history. The first stent came in 1998, and that was developed in collaboration with Kalam Raju. It's called Kalam Raju stent, Abdul Kalam, who was in DRDO,
stent, yes.
and my friend Dr. Soma Raju, they made a stent in 1998, and it was very clear that India, with a huge population, needed indigenous stents because the burden of disease was quite high, and we needed good stents. So came this stent, and within a year of that, the same company, SMT, brought in a stent called Millennium, and that was again a stainless steel stent. And I had a good experience with Millennium, and the SMT CEO or the person who brought up SMT, he's I think in US now, Dheeraj Lal Katodia. Mm-hmm. He was a philanthropist. So he pledged that we need to have something which can save millions of our people. So started the march of these stents till 2001, 2000, and today we have what is called as the Supraflex Cruise, stent, which is one of the lowest strut thickness stents in the market. And then it was decided, thought that, we think that we're very good, but everybody feels that he is very good. You are the best journalist, I am the best cardiologist. So we need some science behind it. So Dr. Patrick Sarais and me designed a trial called Talent Study,
Yes.
which was a study done in all comers, which is a very important thing. No choosy patients. All kinds of patients. Patients with acute myocardial infarction, diabetes, vein grafts, left mains. And it was a sufficiently powered randomized study done in Europe, close to 1,400 patients randomized. And 1 year follow-up was again, device-oriented composite endpoint of death, myocardial infarction, and TLR, that means target lesion revascularization. And it was very interesting results. And it was compared with the market leader, the everolimus eluting chromium cobalt stent from Abbott. And dose was nearly identical, 4.8% versus 5%, and absolutely same, and stent thrombosis rates very low. First time a randomized study showing equivalence of an Indian stent with a international brand with very good results. And if you look at the results, intention to treat is the best way, it was equivalent. But if you see per protocol, the results numerically seem to favor the supraflex stent. But the primary endpoint is from intention to treat. So that was very good. This was a study which was published in one of the very prestigious European journals, as you know, is Lancet. And then we have 2-year follow-up of this study, and the results are maintained.
Right.
There has been no catch-up up to 2 years, and I'm sure 3-year, 4-year we're going to look at. So that was a very important milestone for the Indian stents. But talent, multi-vessel disease constituted only 15% patient, and that also 2-vessel. Diabetic patient population, typically Europeans have lower incidence of diabetes as compared to Indians, and for the matter from North America also, not more than 20-25% patient. So it was felt that we need to do the similar studies in more complex patient population. So 2 kinds of studies were planned. One, again, a European study called, multi-talent, which is about to start,
Okay.
is a multi-vessel disease, triple vessel disease,
Okay.
all triple vessel disease. And it also, we know that there has been a study called Syntax study which had shown surgery is better in very complex patients. So those extremely complex patients have been excluded. Patients where the results from Syntax angioplasty seem to be equivalent or nearly equivalent, they were kept. They are being kept. Study has not started yet. And then randomized between 2 stents. One is supraflex screws, and the other is a stent from Boston Scientific, the Synergy. Because Synergy again is a stent with a biodegradable polymer, unlike Xience, which has a polymer which is permanent polymer, and has got very good results, and is also thin. It's not 81, it's close to 70. So head-to-head comparison. And it also will have QFR measurement, that means flow regulated, that means vessels which need angioplasty. And these days we can estimate QFR, that is like we do fractional flow reserve in the cath lab. There you need to go to the cath lab. But today with the technology, we can measure the flow and the pressures across the lesion, but just by doing an angiogram and computing that angiogram into a 3-dimensional vessel picture and exactly measuring the flow, that is the QFR. And if the QFR is less than 0.8, that means it is significant. If it is more, it does not. So that also will be taken care. That means only vessels which need angioplasty will be done. In all these patients, intravascular imaging will be done. to see the results are excellent. Apposition of the stent is absolutely perfect. And also, these will be followed up for 1 year, 2 years, 3 years. In addition, another very important factor is that we give dual antiplatelet therapy to most of the patients, that is aspirin and clopidogrel, or aspirin and prasugrel, or aspirin and ticagrelor. So in this particular study, aspirin will be withdrawn after 1 month.
Okay.
And only the second drug will be continued. Prasugrel, I think, has been chosen. And this will also tell us that dual antiplatelet therapy is not really required for the long term. 1 month it is required, although Patrick Sorayas wanted that from the beginning it should be one drug only. Why aspirin? Because many of us believe aspirin only contributes to bleeding, and its efficacy in terms of stent occlusion and other things is minimal. But then ethics committees will not allow it, because that is a traditional treatment. Give it for at least 1 month, because there's no study without aspirin in complex patients. So this will give us two informations. Number one, the ultra thin stents in very complex patients. What is the result now? Are we closer to the surgery? And also, is just one antiplatelet therapy after 1 month adequate? Because if you reduce the antiplatelet therapy, the chances of bleeding become low, and bleeding again is an important problem. So this study is going to be very good, and it's going to be started, I think, in the next few months. Then, as an investigator, we thought that why should we not do a study in multivessel disease in diabetic patient population.
Specific to India.
Specific
Because
to
the
India. Talent is a European study.
Was completely a European study. Did not have any Indian patients.
Absolutely.
And as I understand it, the Indian patients are physiologically different because they are smaller built, the vessel size is smaller, and therefore a lot of doctors within India would like to see data coming out from India, because the patients that they're going to treat are Indian patients.
Absolutely.
So I think for that, you're going to be investigating, going to be the principal investigator on another trial called the TUXEDO trial.
TUXEDO study. So that's why we have already started this TUXEDO 2, which basically is multivessel, diabetic patient population, all Indians. We expect to enroll 1,800 patients, 1:1 randomization, possibly 70 centers, because this complex patient population is not easy to get. So we thought that let us first compare the two stents. One is ultra thin, chromium cobalt supraflex screws, versus the market leader, Xience, which is already approved for diabetics, in a very complex patient population with 85% triple vessel disease and only 15% double do that. And I think the 1 year results of this we expect to come by 2022, and then we go on to 5 years.
Okay.
So it's a very ambitious study, and I am very confident that we'll be able to do it very well. And my friend Sripal Bangalore is the co-chairperson of this study from New York. So between two of us, we have a perfect understanding of how to do this study.
Okay. Yeah. Okay. So Dr. Kaul, you're a pioneer in interventional cardiology in India. What is your message to upcoming cardiologists in India, especially now that the government has opened up the sector and we have more Indian stents under the Make in India policy that the government has? And a lot of these stents are also going abroad. Is it a good time to be an interventional cardiologist in India?
Interventional cardiology is a very sought after specialty in cardiologists, because the kind of results you get are really gratifying, and the best gratifying results are in patients with acute coronary syndromes, acute MI, and unstable angina, because there the mortality is high if you don't intervene, open the artery. And I'm proud to say that interventional cardiologists in India are highly skilled with their limited resources. They achieve fantastic results. And my message to them is continue your skills. Don't be, number centric. The number of procedures you do, higher you do is better, but it's not the only way of judging you. Quality of your intervention should remain good, and do interventions only in those arteries, in those patients where it's really required. No unnecessary investigations, because unfortunately the auditing systems in our country are poor, which I always have been telling that we should have some auditing also, so as to give a feedback to the hospitals, because hospitals sometimes have a tendency of, showing them the numbers and, you have not done this and that and emoluments. Let's not get into that. But be honest, do good work, and use the stents which you think are good, effective, and look at the literature, read the literature, and do whatever you think is best for the patient, as if you're treating your close relations, or as if, if God forbid, you get a problem and you want to have to get treated, what would you like to get? You do the same thing. So that's my message. Be honest, be hardworking, do good.
Okay. Thank you, Dr. Kaul. That's a wonderful message to end on. And thank you for speaking to Express Health.
Thank you so much. Thanks so much.
That was Padma Shri Dr. Upendra Kaul from Batra Heart Centre talking to us about the evolution of stent technology in India and his advice to upcoming cardiologists in the sector in India. Thank you for watching Indian Stents Get Updated, and do follow us on Express Healthcare for more such videos.